Okay, we're good to go. Take it away.
All right. Hi, everyone. My name is Dan Mazur. I'm a urologist and part of the Colorado Fertility Advocates group. The webinar tonight kind of decided to focus on my area of expertise, which is men and infertility. So thank you, Ellen, for the crafty name, but we called it Men and Infertility. It's a man's issue too. So just little bit about me. So this is my family. Can you guys see everything? You're seeing it?
Yes, we can. You're good.
Okay. That's my wife, Cho, and that's my son, Wes. We had our own fertility journey, which, I can talk to you later about if you want, but started when I was a resident. And thankfully, we do have Wes, and that's him visiting me in the office the other day, smashing on my computer. But, the fertility team, it really is a team. I mean, this is one of those areas that it takes the village sort of thing. As a urologist, I'm just one of the bubbles kind of over here in the corner. And, we have many people who are involved with the organization and just in fertility care in general who are all on this board. But I always miss some people. So if I missed you and you're part of the fertility team, I'm sorry. But just more to demonstrate how many people it takes to really make this kind of successful process for people. I put these kind of generic photos up because, men are men and, men are great, but sometimes men come into the office and sometimes they're being pushed into the office by their partner, and sometimes they come into the office and have no idea why they're there. So it's not uncommon. I have to get their spouse on the phone to even figure out what's going on. But I think the biggest thing to think about is when we do surveys, while men may not talk about fertility as much, they show just as much of an interest as being a parent. So I think that's an important thing to think about. This is just some tips that really stuck with me from one of my mentors. This is from Dr. Brannigan, who's at Northwestern. He was really, he's a urologist, but he was really my mentor that got me into male infertility. And really said, in this infertility journal, these are the roles of the male partner. So first of all, he is a partner in the process of reproduction. And as we go through that, we need to make sure that we are optimizing his sexual and reproductive health. But at the same time, also not only are they a partner in this sort of journey, but they are also a patient themselves. And we'll dig into this a lot in this talk because I find it very important for men. But there are possibly reproductive and just other health issues that are associated with infertility, and particularly male infertility. And it's well beyond what people may think of. Oh, we check a semen analysis, there could be something wrong. We'll dig into it, but a lot more potential health issues that can happen. So very brief, I wanted to kind of keep this a little general for all audiences, but really the meat of the talk tonight is on kind of the first part, kind of what is the problem of male infertility and why should we care? I mean, that sounds obvious, but I hope to show you a lot more other reasons why we should care. The role of the urologist, so you kind of know what people in my shoes do and bring to the table and can offer. And then just some random thoughts I have in kind of the infertile male that are common questions and things that come up frequently. So just in terms, these numbers are going to vary depending where you look, but they're all roughly very similar. I mean, we know that infertility is a lot more common than a lot of people think. I mean, this is from the WHO, but they estimate about 72 million people globally, and that number continues to climb each year, suffer from infertility. Estimate of about 9% of couples. I mean, that's a lot more than people think. It's 1 in 10 couples essentially could have issues with fertility. And 12% of men just in the United States suffer from subfertility. So these are kind of technical terms, but subfertility, meaning you still have the potential to get pregnant, but it may take longer, you may be having difficulty. This is kind of an interesting slide. So this is from the CDC. This is from 2008. I tried to see if there was a more updated report on this, but I couldn't find one. But I think it's very interesting when we think about men as a population. This study was focused on men aged 20 to 29. I tried to find one for men in their 30s, essentially men of reproductive age, but they didn't have that grouping published. But what it is how many men compared to women. This is a graph of usual source of medical care, meaning they have an established relationship with a provider that they can see regularly. And it's pretty interesting when you look across all coverage statuses on the far left. 59% of men in their 20s have an established relationship with a provider compared to 80% of women. And those differences really can skew depending on the population with their insurance coverage. So private insurance, that skew is even higher, 69 to 90%. And the uninsured population is significantly lower, have established care, which is an obvious problem. But you can see, particularly young men of childbearing age often don't have routine medical care or have an established relationship with a physician. This slide looks very similar, but it did flip. This is kind of just looking at doctor's visits in the past over a year. So again, you can see a very similar sort of skew. Women generally go and see a physician more often than men do, 60% compared to 86% across all insurance coverage statuses. I put this slide on just to kind of demonstrate how well women have done as advocates for themselves, and men sometimes not as much, and more of a jealousy issue. We wish we can do just as well, but this is a chart comparing funding for cancer research compared to deaths of that cancer. And the two most common cancers in the world, and at least the US, are breast cancer is the most common cancer in women, and prostate cancer in men. But you just compare the breast cancer on the left to prostate cancer on the right. Breast cancer receives significantly more funding than prostate cancer, despite a very similar incidence. And breast cancer had a little bit more deaths, but not too far off, but also compared to many other cancers. So, I consider this just a big win for people who are advocates for breast cancer and women's health, and it's amazing. We obviously just wish we could mimic that in other areas as well. So just kind of an interesting slide. This is, if you've ever done fertility stuff, people have talked about these pie charts, and you'll hear everyone kind of quote different numbers. But actually, I went back and find the actual resource or the reference, and it was all the way from 1991. This is a French study, but people generally would say 25% of fertility issues are male, 50% are female, and the rest are a little bit of both. But the actual study showed that when you look at contributors to infertility, female factor is the factor in 30% of cases, male factor 20% of cases, both in 40%, and then there's this 10% which is unexplained, meaning we don't know, could be either. So I think the interesting thing, if you look at that, that means 60%, or if you include that 10%, up to 70% of fertility issues in a couple could actually be male related. This is a study from a Dr. Agarwal, who does a lot of kind of fertility stuff, but this is more looking kind of globally. So I know it's a big chart with a lot of numbers, but essentially this is looking at kind of fertility stats around the world by region. The left column is males. The middle one is couples that are reported infertile. And then the far right is couples where they think of male factors involved. So, infertility issues do seem to vary depending on region of the world. It's not reflected in this chart, but the highest rate of infertility is actually a small area in sub-Saharan Africa, close to Tanzania, where they say up to 40% of couples have fertility issues. They call that the infertility belt. But across the world, they're saying male infertility, 4.5 to 6% of males are infertile in North America. By North America, they mean the United States. Highest rates in Central and Eastern Europe, up to 12%. But when you look on the far right, male factor, again, kind of similar to that pie chart, is contributing anywhere from a third to up to 70% of cases, depending where you are. The stats in the Middle East are a little bit difficult, so they don't report them, but male factor fertility is a lot higher in couples than that. It depends kind of in the region in the Middle East. There is some factor of consanguinity as well, depending on the area as well, but we do see that a lot. This is just another chart that's kind of similar, and for me, it's more of the area on the far right, just kind of putting the numbers to some of these percentages. I mean, we are talking of millions and millions and millions and millions of men across the world that are dealing with infertility issues. So this is obviously much more common than people think. This is just kind of a map to kind of give you a little more visually as opposed to those charts. But, you know, they say male infertility contributes to 50% of cases in North America, and it kind of varies across the world. But Eastern Europe has currently been reported amongst the highest at 55%, and also the Middle East at 60 to 70%. But you can see it's a significant factor kind of anywhere you go in the world. You know, also, why is this important? Well, you know, since it is so common, this is from the Kaiser Family Foundation, some information. This is on couples. They put as their women and their partners seeking fertility services. Essentially, all they did was survey women. They did not survey the men, which is something that's very interesting you'll find. It's very hard to find the similar studies for many of these things done on male partners. So they just extrapolated from women and said, oh, this will apply to the group then. But 7% of women, this is in Northern California in the research group, sought fertility advice at some point. And 6% pursued with testing, 5% were on fertility drugs, 2% with insemination, 2% with other procedures. So, you know, these are pretty significant numbers across the population. This is just some information for you from the National Survey of Family Growth. So they estimate 7 million couples a year seek fertility services. This is in the United States. And really interesting, and this is something that pops up a lot, 27% of the male partners were never evaluated kind of on their infertility journey, which is kind of shocking because all the prior stuff I just showed you said that, you know, on average, about 50% of fertility issues are male factor related. There was what popped out and what led to more males being examined was the longer the duration of the infertility and also being white or Caucasian race. This is from just some conclusions from that paper of Mike Eisenberg. He's at Stanford. He's a urologist who does a lot of infertility kind of population work. But the first line is kind of in reference to when we showed those charts of how many men actually have established care with physicians and go see physicians. But unlike women who usually have a gynecologist since their teens, most men do not have a urologist or a regular physician. They do not seek routine medical care. Also, you know, on our end, as the provider end, it is getting better with training, but many urologists, they are not well trained, and not all programs have great fertility training programs. So, you know, a good chunk of people, unless they specialize it, are either uncomfortable or can be reluctant to kind of get involved with infertility issues. And then one of the other perceptions, which may be why are men not getting evaluated or being considered in the infertility journey, is because in some areas on the internet and the media, you know, IVF and ICSI has become so good that sometimes it's painted as a cure-all for fertility failure. So, you know, oh, we don't need to work that up. We can just do IVF sort of thing. But it's important when you think about the male. So no, we don't know all causes of male infertility issues. And that's the farthest left column here. It's the idiopathic column. So 32.6% of cases, we're not going to know the exact cause. But in 2/3 of the cases, you know, we can find a cause. And the things that are important here, I'm going to highlight, are potentially treatable things. So the varicocele, that's some dilated veins that we can do surgery on. That's one of the most common issues we see for low sperm counts and low motility. Obstruction, now that can be various different things. I mean, the most common is a vasectomy, but there are congenital things as well. Ejaculatory failure, that tends to be more diabetics or people with spinal cord injuries can have difficulty ejaculating. but they usually don't have a problem producing sperm. So that's something that can be worked around. Endocrine, I personally think this column's a lot higher. I think they're talking about true endocrine problems, pituitary problems, that sort of thing. But if you lump in testosterone usage in the modern society, that number is going to be significantly higher. Radiation drugs, radiation is an effect that we can't undo, but certain drugs, potentially we can counteract or stop. Sexual dysfunction, a lot of people don't really think about that as much, but, fertility issues are a couple's sort of issue, and sexual dysfunction can be a component of that, whether that's erectile dysfunction, intimacy issues. Those are all important considerations, and sometimes we can help with some of those as well. Obviously, infections can sometimes be treated, but those things that I starred, that's almost half of the things that are causes of male infertility potentially could have some treatment. So that's why it's really important to have the men evaluated. The things that are otherwise on the far right, genetic and cancer and testicular failure, not so much. But at least half of the things, we may have some hope to try to make things better. And why is that important? I think a lot of people who are involved with infertility know some of this information, but infertility treatment is very expensive. This is also from the Kaiser Foundation, so this is in California, so maybe a little bit higher than what we see around here, the national averages. But, an in vitro fertilization cost per person, they estimate is $24,000. They say cost per success, meaning embryo transfers, actually coming home with a clinical pregnancy, can average cost up to $61,000. IUI is obviously a little bit cheaper, but still not cheap. So if we can help a couple and improve semen parameters and improve fertility and potentially even bump somebody down what they need on this chart, there potentially could be some cost savings for the couple as well, or which can potentially open up more doors to what they can do. For me, this is one of the most kind of important things with all of this. It's sometimes easy to, lose the forest for the trees sort of thing, but this was going back to the initial slide with Dr. Brannigan. Yes, our goal is to help this couple and this man become a father and become pregnant as a couple, but we also need to care about the man himself. And there's a lot of data that has accumulated, particularly over the past 10 years, that potentially an infertile male could generally also be a less healthy male. A lot of data coming out that infertility could also be a marker of overall poorer health in that man. The prevalence of comorbidities in infertile men is definitely higher than fertile men. It's been reported as 21% versus 9%. The most common is hypertension, hyperlipidemia, so it's high blood pressure and high cholesterol. But obviously those can have significant impact on men's cardiovascular health. They can also affect erections and other sexual things that could be important to fertility as well. In men who have azospermic men, or men who have no sperm, they've shown a general 2.2-fold higher risk of cancer. Now, this can be all across the board. There is some stuff on testicular cancer. While it is still an uncommon cancer, an increase is still an increase, but still rare. But other cancers have also been associated with infertility as well. Another study, this also from Dr. Eisenberg, showed that in men who have at least 2 deficiencies in their sperm parameters, so that's count, motility, morphology sort of thing, they did a study where there's national databases on like death, and and they've looked up those patients at several institutions, and they kind of followed them in these databases. And men who had these more than 2 deficiencies in their semen parameters had a 2.3-fold higher mortality risk over this 20-30-year period they were looking at. So clearly there's something correlated potentially with health in some men. They've shown an increased risk of heart disease. So those are what's called hazard ratios. So essentially a 1.48 times increase in ischemic heart disease. Diabetes is increased, alcohol abuse, drug abuse. It's important to kind of think about some of those other potential health things and the stress of fertility issues leading to increased drug and alcohol abuse, and the health impacts on that as well. It's also important to think about the mental health. And this is what I opened up with is, yes, men may think less about having children, but they have a similar desire to actually be a parent. So it's important to kind of keep that in mind. I think the whole masculinity thing is sometimes a problem, sometimes getting men in the door to be evaluated in the first place. I think that's changed a lot over time. But depending on cultural norms and religious considerations, some of that can kind of still come into play. And I think you need to be very sensitive about the patient and the individual and their wishes and what they're open to. And in some cultures or belief systems, masturbation to check a semen sample is not allowed. So, there can be some difficulty with some of that as well. But you really need to kind of consider all of that to help an individual with their journey. It's not known why more health issues are found in men suffering from infertility. There's some hypotheses that potentially some of it is genetic, meaning there could be a genetic cause for their infertility issues, and could that be associated with other things? The most common things we see are some hormonal issues. Testicular dysgenesis essentially means issues with formation of the testicles during puberty. So kind of the sperm stem cells called the spermatogonia undergo development during puberty. You start making sperms. It's called spermatogenesis. So potentially something associated with that issue could also be associated with health. Obviously, psychological stress, stress in general pretty much doesn't help anything, but also it leads to increased substance use. Smoking has been shown to impact fertility. Alcohol is a little bit more controversial. Studies are a little conflicting, but definitely marijuana. And I feel like it's leveled off a little bit, but it was a big issue here with the legalization in Colorado. And we'll talk a little bit more about that later. So I hope that kind of gives you a little bit of insight into, this is actually a pretty significant problem. And 50% of men, are also involved with some of the infertility issues in the partnership. And obviously we should care because we care about the men and we care about their health as well. So just a little bit on what the role of the urologist is. So, I mean, in one line, this is kind of our role is to evaluate and treat the male partner. And these are just kind of the really high level questions when someone comes in that we ask. I mean, the first line is really important. Do they have sperm or not? I mean, that if you have sperm versus you don't have sperm, that really dictates considerations and workup and potential options on the table. And then our goal is to take that and say, are there any room for improvement in the sperm parameters, whether that's trying for a natural pregnancy or to help with ART, which is IUI or IVF assisted reproductive technology. Questions of if we don't have sperm, do we need to try and find or get sperm? And then again, health considerations for the male as well. What we do when someone comes in, obviously a detailed medical history, this is important. A lot of people write they take no medications, and then you ask them 3 times and then they tell you they take testosterone. So it is really important to kind of go through the history and go through it in depth. Physical examination, I have another slide on that. I cannot stress that enough. Sometimes there are cases with infertility issues. On a 1-minute physical exam of the genitals, I can tell you what's going on, or at least have a good idea. Sometimes laboratory evaluation, essentially blood work, hormones, genetics, depending on the case. Sometimes we do some imaging tests, depending on the case. Not super commonly in infertility, but in certain situations, there's some imaging tests that we do. And then if we need to, in some cases, there are some potential surgical considerations, whether that's surgery to improve sperm parameters or surgery to obtain sperm. Physical examination, just wanted to show you, I mean, this is really important. Cryptorchidism is an undescended testicle. You'd be shocked how many men have had that, and depending when it came down or they brought it down, that can really affect development of the testicle. There's also men, I mean, I see maybe 1 or 2 men a year come in for a vasectomy, and they don't even know that they only have 1 testicle and the other one's actually undescended. So this is very common. Testicular atrophy can be a sign of genetic issues, hormone issues, production issues of sperm. I mentioned earlier, varicocele, these are dilated veins that essentially increase the heat in the scrotum, and the testicles like lower temperature to make sperm. So that's potentially correctable. This is technical terms for unilateral absence of the vas deferens or congenital bilateral absence of the vas deferens. Essentially, what a lot of people don't realize is there are actually a lot of men who are actually born with a vasectomy. For all intensive purposes, they're born without a vas tube. Much higher rate in Caucasians, much higher rate in people. Most people who have this are carriers of the cystic fibrosis gene, not always, but I see almost a couple men a month who have this and they don't even know it. And then certain genetic things, most common one we see is something called Klinefelter syndrome, which is you have an extra X chromosome, so you are XXY. But it's really important because a lot of this stuff, you can get a very high suspicion or a diagnosis based on a quick examination. And then, so just some general considerations for the infertile male. Some things that kind of come up and just some of my thoughts, but I think some things that are kind of helpful. Marijuana, I mean, this comes up a lot. I think particularly since the legalization, marijuana usage has increased. And it's actually been shown that so the THC receptors, the cannabinoid receptors, I try to say that one 10 times fast, cannabinoid receptors, they've actually been demonstrated on sperm themselves, meaning THC actually can directly affect sperm through the receptors. They've shown it decreases count and concentration, can decrease the motility, that's the swimming of the sperm, can alter the shapes, the more abnormal shaped sperm, that's the morphology. It can inhibit how sperm essentially function and fertilize an egg. And then we do see in a decent amount of men some hormone issues related to heavier marijuana usage, decreased testosterone levels. Sometimes there's some weight gain associated with it, and that can all affect libido and sexual dysfunction. Obviously, this can be highly variable depending on the man. But it does come up a lot. So that's kind of also a potentially correctable issue as well. Testosterone and male fertility. So this is huge. This is probably the biggest thing we see. There's this perception out there of this, super muscular man as what testosterone will do for you. And this is kind of how it's sold to men. So look how depressing low testosterone is on the left with all the symptoms of depression, Alzheimer's disease, increased fat, ED, low libido, increased risk of low bone density as osteoporosis. But if you take testosterone, you'll have a sharp mind, confidence, you'll have, it's not quite a good smile in that guy, but a happy smile and increased muscle mass, strong erection, strong bones, plenty of energy. It sounds like a cure-all, which is why it is talked about and sought for by so many men. And if you really are low, it can help some men, but you really have to caution guys, it is not a magic bullet that will cure all. I did this a little while ago. There's probably more now, but this is just a little snapshot kind of in our south part of the town where I'm located in our office. And these are, if you just Google testosterone on your Google Maps, these are all the clinics that pop up to give men testosterone. A lot of them have some interesting names, but there's a lot of them. This is very technical, but at least just want to show you why is testosterone a problem. Well, they did a survey about 10, 15 years ago, and it was 40% of practitioners said that if a guy had low sperm counts, we should give him testosterone. Well, that's actually the exact opposite thing you should do. Intratestic, or in the testal, testosterone is important. It stimulates the Sertoli cells to make sperm. However, when you take testosterone, that's on the far right, it actually has a suppressing effect on the brain. So essentially the brain thinks the testicles are making more testosterone than the brain is telling them to do, and the brain actually stops or really decreases stimulation to the testicles. So when people joke about people using steroids or bodybuilders getting shrinkage of their testicles, that does happen when you take testosterone, and it shuts down sperm production. They say about 60, it varies, 60–80% of guys can have complete shutdown of their sperm production, nothing in the ejaculate, within 4 to 6 months of taking testosterone. So we see that a lot. And sometimes it can be hard to treat because some men do get a significant benefit in their quality of life. So trying to get them to stop can sometimes be a little bit of a process, but we can work on that a little bit. But this is what you see. It's very clear to us usually on exam when a guy is on testosterone. because the grape sometimes becomes a raisin. And the job of the testicles is to make testosterone and make sperm. And if it's becoming a raisin, usually sperm production takes a hit. COVID, I mean, COVID is a big thing these days. Everybody's talking about COVID. It's everywhere. But obviously people have started to look at it for fertility. I would say for male infertility, there's not great information or data, usually small reports, case reports, anecdotal things, but there are some studies coming out. So there's one study from China where they looked for COVID PCR testing in the semen of men 1 month after they had an infection. And they did not detect any COVID 1 month after the infection, the actual semen itself. There's another study where on autopsies of men who had died of COVID, and granted, these are various ages and comorbidities, so there's some potential confounding factors. But men who died of COVID generally increased germ cell loss. Those are kind of like the stem cells and the testicles that make sperm, and sloughing, meaning loss and death of these stem cells that make sperm, compared to men who had died of non-COVID causes. And the severity of the COVID seemed to correlate with that as well. So, I can only give you kind of more anecdotal stuff from our practice, but I am becoming more convinced that I'm seeing more men who had COVID, particularly severe COVID with high fevers, that we are seeing some changes in their semen parameters. The one that seems to worry the most is the swimming or the motility. I think that will be kind of more of a time will tell sort of thing, but we do know a lot of viruses can actually go to the testicles. The classic one historically was mumps. So yes, there's a vaccine for mumps, and a lot of people are vaccinated against mumps. That's the MMR vaccine. But there is a percentage of boys who get mumps that it will affect the testicles and can make them sterile. So we know viruses can do this. We know high fevers, particularly stress on the body, can really significantly impact sperm production. Interestingly enough, I actually came across this one I thought was interesting. If people are worried about the vaccine and their fertility, they actually did a study where they checked men's semen parameters, then had them do 2 shots, the standard kind of regimen. I can't remember if it was the Pfizer or the Moderna, but of one of the mRNA vaccines. And then 75 days after the second shot, had them giving another semen sample. And you got to take it with a grain of salt, but this is called a waterfall plot. But the guys on the left, essentially more guys had an improvement in their parameters than a decrease after vaccination. I would kind of take it as a wash and say, all right, vaccination shouldn't affect your fertility. While this is statistically significant, if you look at the change, it was 36 million swimming sperm to 44 million. And while that is great and statistically significant, it may not actually be that clinically significant. But at least you can say from the data that we have, we don't think vaccination is going to have a negative impact on fertility. But again, these are limited studies. The semen analysis. So the semen analysis is kind of an amazing test, and I talk about it all day long. This is kind of a chart comparing how things have changed over time and what is considered a normal semen analysis. Now, what is considered normal semen analysis to this day is still considered controversial. We did a study when I was a resident, which was like 10 years ago now, where we actually cold called andrology and infertility labs and asked them what they use as normal parameters for semen analysis. The most common is what's called the World Health Organization criteria, the WHO, but it was only about 70% of clinics actually use that, and the other 30% had their own internal criteria. So the interesting thing from that study was, depending where you went as a man, sometimes you were normal and sometimes you were abnormal, depending on what they considered normal parameters. What has been interesting is what is considered normal, as you can see from left to right, has significantly changed over time. Some of this is some variability in testing, and the biggest one is on the shape of the sperm, that one, the morphology. They went with where it started in 1999 to kind of more of a strict criteria. It's modified a little bit over time. But you can see also, depending on the area, particularly in counts and motility has also gone down as well. So it's kind of an interesting trend. The reason, I know this is a big chart, but I'm just highlighting something here for you. The semen analysis is a little controversial is, we know men who have poor semen parameters, who have multiple children, and men who have amazing semen parameters who are struggling for fertility. So the debate has always been what is considered normal. If I go back to this chart, those first couple of values on the left were essentially just expert consensus. So a bunch of people would get in a room and say, this is what we think should be a normal semen analysis. In 2010, the World Health Organization essentially collected a bunch of data from around the world, a bunch of smaller studies on men whose partners got pregnant within a year, and took all their semen parameters, put them on a curve. So you have the average and the standard deviations, and they essentially just drew a line at the box I'm showing you, the 5% mark, and said, this will be normal abnormal. So this is kind of the best thing they could come up with for the modern era, given the limitations of the test. But the interesting caveat is every single person who was considered abnormal in that study had a proven for pregnancy within a year. So we have to kind of very individualized interpretation of the semen analysis, but it is definitely a good screening test to indicate, is other workup indicated, what are other potential concerns? Obviously, if there's no sperm, that's a whole nother discussion. So I just like to bring that up because this is something we talk to our patients a lot about. So it is a helpful test, but it's not always the end all be all for all people, but it is very helpful. And the other thing to know is semen parameters can vary a lot over time. So this is actually from the WHO's manual on how to do a semen analysis. I pulled it out of there. But they followed men over time, and you can see this is over years, and had them give random semen samples. And most men are not stable. I mean, some men have significant fluctuations in their sperm counts. So that's why the teaching is always, if you have an abnormal semen analysis, you should always get a repeat. But we know these values can change a lot over time. So just something to kind of consider. There are a lot of people around, and also at this organization, who are a lot more involved with things such as fertility preservation. But I think this is kind of a really interesting area, and I think it's becoming more of a conversation and something we see a lot more in clinical medicine. But the idea essentially being, if somebody is going through something that could affect their fertility, trying to help them preserve some fertility, i.e. freezing tissue or sperm or eggs, whatever, before they undergo therapy. This started off kind of more in the oncology world, where a lot of people, and we still see some people who underwent chemotherapy or radiation, and now it's really affected their fertility, and they're like, well, I wish I would have frozen sperm beforehand. So as time has gone on, this has gotten significantly better, and people are more educated, kind of in the pathway of how to counsel people as they go through these sort of therapies. I think thankfully this is also becoming a lot more common in the transgender population. People, before they undergo hormone therapy or surgical therapy, are considering if they would want to do this. They did a survey in transgender population, and they said before hormone or surgical therapy, the majority of people wanted to consider doing some sort of fertility preservation, but for various factors, only about 10% ever actually sought it out, whether that was financial or emotional, but thankfully that is being talked about a lot more, so we can provide those kind of services to a lot of people. One of the biggest areas that people are talking about is using it for children. So one of the most difficult things is someone who has not gone through puberty yet, who is going through a potentially ablative therapy for their future reproduction. This is most common in cancers in children. Leukemias, lymphomas, blood cancers are the most common. Many of those agents are quite toxic. It is great that childhood cancer survival rates have improved significantly, and those treatments have done it. But now, as these children are now becoming adults and they're thinking about their fertility, people have quickly realized there are other discussions that are happening. So many institutions now are offering programs where we can biopsy a testicle and essentially freeze it. It is still a work in progress, and could you stimulate sperm production down the road and potentially reintroduce that into a person? It's being studied in the lab and in animal models and that sort of stuff. And there's some promising data, but it's still quite early and a little bit more hit or miss. But I think that's kind of a really interesting area for the future. But I think it's important for people to know about, so they can counsel their patients appropriately who may be undergoing this sort of thing. Just one of the other kind of quality of life things. Hey, we need to get you through this process, but we also need to think about the future as well. Kind of just the last thing I want to leave you with. There's some cool stuff that's out there, and is this what I'm going to show you something that would ever be a clinical reality? I mean, probably doubtful, but it's kind of interesting that people are looking at. I think National Geographic actually talked about this. But this is actually, a coil is actually a metal coil that's been controlled by a technician with magnets. And they're actually picking up a sperm that's non-modal, so sperm that's not swimming, and injecting into the egg. Now, granted, it's kind of just getting stuck in the outside of the zona pellucida of the egg, but pretty cool stuff they're talking about. They call them sperm bots or micromotors. Essentially, are there ways that we can potentially make these more usable, maybe more in an in vivo setting that's in the body as opposed to in the lab and in vitro setting. So I think more just kind of food for thought, but some interesting stuff that's out there. So I think that was about 45 minutes. So I hope that was just a little bit more of kind of a helpful overview. But again, my goal with this was just to kind of provide some awareness to how big of an issue male infertility actually is, and how much it actually does contribute for a lot of couples kind of on their infertility journey. And the fertility part is part of it, but we also need to care about the men and the men's health through this journey as well. And then just a little bit of information on kind of what a urologist can do, what are some things maybe we can consider from the male end. We can go very into depth in a lot of those issues, but I wanted to kind of keep it brief kind of for the time being. So thank you. I hope you guys found that helpful.
Does anyone have any questions?
Yeah, I do have a question. This is Bernard.
Hi. Hey, Bernard.
Hey, how are you, sir?
Oh, good.
2 questions. Well, I'm on here as definitely somebody on the fertility journey with my partner, as well. I'm also a nurse practitioner. So 2 questions. Historically, what has prevented insurance companies from covering fertility in their programs? And also on the dietary approach, are there any considerations that maybe can bring us back to 1980?
Are you talking about with the 1980, like the sperm parameter stuff, or?
Yeah, because you showed that fertility is generally, yes. So
the sperm parameter thing first. So there's some data. I wouldn't say it's something to hang your hat on, that semen parameters may themselves have changed over time. That chart was more what is considered normal has essentially changed. So not necessarily men have changed, but there is some data that men have kind of changed over time. And that's a lot that people are talking about, environmental things. People talk about cell phones, radiation in the environment, things we're eating. Thankfully, over the past 20 years, people have realized the amount of chemicals and additives that were in our foods, plastics. In certain foods, the one thing we worry the most about with men is high estrogen content. A lot of men don't realize, particularly vegetarians, that some vegetables actually have high estrogen, particularly like soybeans and things. And estrogen, if you go back to that chart where I was at with their testosterone, is the biggest negative feedback, actually more than testosterone, on the brain to actually shut down sperm production. And also a lot of supplements. Supplements are not regulated. So a lot of supplements can actually contain estrogens that people don't know about. So that can be a little bit hard. But dietary stuff in general, it's difficult. I think for anyone's life, the cleaner you eat for your general health, the better. I will caveat that with one thing. I reviewed a paper not too long ago for Journal of Urology looking at testosterone. So testosterone, the main male hormone. People don't realize testosterone, estrogen, a lot of those hormones actually come from cholesterol. So the base molecule is actually cholesterol. So in order to make estrogen and testosterone in your body, you actually need cholesterol. So they've shown that people who have low cholesterol diets actually had the lowest kind of testosterone counts, and potentially that stuff could impact fertility. So it's kind of interesting. Obviously, you don't want to take a ton of cholesterol because then it impacts your cardiovascular health. So it's all kind of a balanced diet sort of thing. But the flip argument to that, I think people with significant fertility issues, for most of those people, dietary things aren't going to have a huge impact. It's more taking testosterone, medications, history during puberty or pre-puberty that could have affected the testicles. Everyone's different when it comes to fertility vitamins and supplements. My party line is, I think in general, they're pretty low risk. They may not always help, but they're low risk. So I think they're okay. Our national society, the American Urologic Association, doesn't recommend fertility vitamins and supplements routinely. They just don't think the data is robust enough on them. But again, everything in life's a risk-benefit ratio. When you're talking about coverage issues, I mean, honestly, that's what a lot of this organization is involved with. I mean, multifactorial, but I think number one for insurance companies is probably always going to be cost. As I showed you that slide, I mean, you know, a couple of needing in vitro fertilization things is significant. And, you know, unfortunately, or for whatever your opinion, insurance companies are, for the most part, for-profit companies. So they look at things from a numbers perspective and have massive accounting teams. So, you know, that is involved in decision-making as well. Yeah, Bernard, I don't know if you know, they passed, like, you know, 2 weeks ago now, the governor did sign a fertility bill. So hopefully that's going to increase coverage. I think we'll need to wait and see, you know, particularly on the male end, you know, how it actually looks and starts to play out. But, you know, I think the future, particularly in Colorado, is definitely getting brighter and brighter. And that's thanks to a lot of people who are actually on this call as well, who really kind of helped get that bill going. So, yeah, I hope that helped. Okay.
There is a question in the chat too. What kind of things can males do to improve their fertility, particularly males going through IVF with their partners, lifestyle changes, particular supplements, bad habits to avoid?
Yeah, I mean, obviously it really does depend on the individual and what they're doing. We talked about the supplements. I mean, the marijuana is a big one. We see cutting that out and not taking hormones unless we're giving you the hormones, because a lot of people don't understand how they actually work. There are certain medications that can affect it. Honestly, in young men, one of the biggest medications we see is Propecia or finasteride. A lot of men take it for hair loss. That can actually significantly decrease sperm counts. Heat is something that's talked about a lot. Most of that data came from fixing those varicocele things, but a lot of external heat to the scrotum in general is not good. Your testicles, like 1 degree lower on average temperature to make sperm, which is why they hang out of the body actually in the first place, can go up and down with temperature. So they most talked about things as hot baths and jacuzzis and saunas, those sort of things, kind of soaking in hot water. But there's been studies on laptop on the lap and heated car seats as well. Those are kind of the biggest lifestyle thing. Everything else is kind of individualized, depending on, you know, past medical history and other medical problems, sort of thing, depending what's going on. But those are kind of the biggest, easiest sort of, like smoking. That's the other thing too. If we generally think about it, if you're putting some toxins in your body, theoretically it can kind of go down to the testicle. The other thing is hard to avoid, but serious illness can really shock the testicles. I mean, we see it a lot. That's where more stuff's coming out with COVID, but you had a high fever. I saw someone who had COVID who had 100 million sperm in his ejaculate, which is perfectly normal and amazing, and he went down to 0 within like 6 months after a really severe COVID illness. So easier said than done on the prevention front, but that's something that we just see out in the community as well. So.
And John, did you have a question?
I did have a question. I'm a big YouTube user, and of course I recognize that not all YouTube videos are credible. But I did see one recently with Elon Musk, and, you know, everybody's talking about Elon Musk, and someone asked him, you know, what does he believe that the 5 primary ways, what the 5 primary things that could happen to cause the extinction on planet Earth? And believe it or not, I think it was the second most likely event. He said was the global significant reduction in the global fertility rate, which I was just shocked. And then he had some statistics, and he talked about how sperm counts over time have decreased dramatically. So I was wondering if you had any comments on that. It really did get my attention. Not that I think the world's going to end because of.
Well, no, I know. I haven't heard that direct from him, but I have heard him talk about how, you know, he has he wants to have a lot of children. I think he already has a good number already because he has concerns about that for the world as well. But, you know, that was some of that stuff I was showing kind of earlier on. I mean, the high percentage of fertility issues, and those numbers just seem to go up every time someone publishes a study and looks at it. I mean, heck, that one area in sub-Saharan Africa where 40% of couples now are dealing with infertility issues. So it's huge. I mean, obviously there can be some biases and that sort of stuff, reporting biases. A lot of those are kind of survey-based stuff. And, you know, I think as awareness increases and maybe people talk about it more, you know, 40 years ago, if you were not getting pregnant, you know, you adopted or you know, kind of moved on and didn't have children. So there's some limiting things. The stuff on the sperm counts going down, I mean, that is published. And I personally do believe some of that. Part of it may be in how they do semen analysis a little bit, like with shape and things. So you gotta be careful on exactly what you're looking at because they've changed how what they actually call normal in some parameters. But yeah, I do think it's kind of going down. And, you know, generally some of that may be associated with people seeking their fertility journey a little bit later in life, you know, maybe not early 20s, but mid 30s, late 30s, early 40s. It's not uncommon these days. So that has to have an impact as well. But I think clearly, you know, our environment is changing as well. And you know, we talk about global warming, but, you know, potential health issues as well. So yeah, I mean, I do believe a good chunk of that data, but you know, some of it's not perfect, but I think the summation of it is definitely really intriguing.
Thank you.
Mm-hmm. Well, cool. Thank you, everybody. I hope it was helpful, at least just kind of give some insight from our world. Obviously something I'm kind of passionate about, but you know, I think there's a lot of potential help and further increase of awareness kind of around these issues. So thank you.
Thank you all. I will stop the recording now.